Hey everybody, it's low carb and keto nutrition specialist Amy Berger bringing you, as always, keto without the crazy. I've got another long video for you today, and this is actually sort of a follow-up or a part two to a video I did recently called What You Need to Know About Alzheimer's Disease. So if you haven't already watched that one, I do recommend that you put this one on hold and go watch that one first. You're going to be able to understand this one much better if you've already seen that one. However, if this particular topic has you, raring to go and you really want to watch it, you can understand it. You will be able to make sense of it without having watched the Alzheimer's video, but I really do recommend that you take the time to watch the Alzheimer's first if you can. Okay, without further ado, like I said, this is sort of a part two to that video. Today, I will be talking about ketogenic therapies for neurological and neurodegenerative conditions. So this builds upon what I explained in that Alzheimer's video, and I'll be talking about other neurodegenerative conditions besides Alzheimer's. Excuse me. So let's see. Anything else I need to tell you before we get into things? No, I think everything will be revealed as we go. As always, we offer up that little prayer to the technology gods to make sure that the slides display well and everything goes smoothly. I do want to say that when I record sharing my screen so you can all see the slides, I know that I appear in a little thumbnail box at the top right of the screen. I've tried to organize my slides so that that little picture window of me doesn't block any of the information on the slide. But in some cases, I do think I'm going to get in the way of some of what's on the slide. I don't think that's going to hinder your ability to understand and appreciate any of the presentation. But if anyone out there is interested in the slides, I am more than happy to share the entire slide deck with you. Simply send me an email through my website, stallslayer.com. There is a contact form. You can just send me an email and let me know that you want the slides from the talk on neurodegeneration. Okay. Those of you who happened to watch my thyroid video a few weeks ago, I will kind of echo what I said there. This is a presentation that I have given previously at low carb and keto conferences. But the good thing about being able to do it for my own YouTube channel is that there's no limit on my time. I can take as long as I want to cover everything I want. So again, this is going to be another long one, but I really, truly hope that it is helpful. And one more thing that I think it's important to say before I forget, that I'm going to present one major perspective on neurodegenerative issues. This is only one perspective. Of course, there are numerous other things that can contribute to neurodegeneration. I covered some of them in the Alzheimer's talk, such as vitamin B12 deficiency, use of statin drugs that can interfere with proper, neuronal function and neurological function. So there are other factors, and there may even be infectious agents and environmental toxins that can contribute to some of these conditions. So by no means do I mean to imply that what I'm going to cover in this presentation is the end all be all or the only contributing factor. It certainly isn't, but I think it's a very, very huge part of the picture. And it's something that you need to know about if you are currently living with one of these issues, or if someone you love is currently living with one of these. And unfortunately, the reality is, because of the prevalence and the increasing prevalence of some of these conditions, most people out there watching probably, unfortunately, do know someone who is afflicted with one of these. So without further ado, here we go. And I really hope this is helpful. Let us get into the slides. Okay, there we go. So this is ketogenic therapies for neurological and neurodegenerative disorders. And there is a reason I use the phrase ketogenic therapies and not ketogenic diets. And I'll get into that a little bit later on. But if you're wondering, ketogenic therapies, why doesn't she just say ketogenic diet? There's a reason for that. So in case any of you watching this is brand new to my channel or brand new to me, and you didn't see some of the previous longer videos I've posted recently, I do want to give you a quick introduction as to who I am and a little bit of my background. My name is Amy Burer. I am a low-carb and ketogenic-oriented nutritionist and writer. I have a master's degree in human nutrition, and I am a CNS. That's Certified Nutrition Specialist. It's different from a dietitian. I'm not a registered dietitian, but I do have graduate level certification and education in nutrition. I'm the author or co-author of 3 books. You see them at the right of the slide there. Pardon me. My first book was The Alzheimer's Antidote, which is, you will learn more about the whys and wherefores of that in this presentation. Book number 2 is The Stall Slayer. That's all about breaking fat loss stalls on low carb and keto diets. And my most recent book is End Your Carb Confusion, co-written with Dr. Eric Westman from Duke University. Working on book number 4 right now, which is going to be all about thyroid. So if you are interested in thyroid and you missed my thyroid talk, go to the channel and look for it. You will love it. All right. I have spoken at low carb and keto conferences in the US and abroad. I helped write the curriculum that the American Nutrition Association uses to certify other CNSs in the ketogenic diet. And I served on the committee that writes the board exam to certify CNSs. So that's just a little bit about me. And let's move on. So as I stated, I'm a nutritionist. I'm not a doctor. I'm not a medical professional. Nothing in this presentation is meant to be medical advice. Please always work with your medical team. Okay. Why do we need to look at ketogenic therapies for neurological or neurodegenerative conditions? That is a mouthful. Why look at ketogenic therapies? Well, the very, very sad reality is that this is the standard of care, what you see here on this slide. Take your meds and say your prayers. Is this the best we can do? Is this really, truly the best that we have to offer people who are suffering from these conditions? There's got to be something else out there. So again, why ketogenic therapies? Well, the conventional treatments are lackluster, right? There are some drugs that are prescribed for these conditions, but they're frankly not that effective. And if you or someone you know is afflicted with one of these issues, you know the drugs don't really do a whole lot. There are treatment-resistant cases, and that means that some people don't respond to the drugs at all, really. So even when there are drugs that are somewhat effective, some people simply don't respond all that well to them. There's a decline in the efficacy of the conventional treatments. So even in cases where the drugs do work, over time, they stop working as well. So they lose their efficacy in terms of fighting these issues. What about the side effects of some of these pharmaceutical drugs? No drug is without side effects, none. And some of the side effects can actually be quite dangerous and quite severe and serious. And as one example, some of the drugs used for Parkinson's disease, because of the way they affect the dopamine system and the reward signaling system in Parkinson's, they come with increased risk for risk-seeking behavior, like compulsive gambling, compulsive shopping, all kinds of things that this person normally wouldn't do. These drugs can actually induce those side effects. So is that really the trade-off that we want to make? Hey, great, your Parkinson's is a little bit better, your tremor is a little bit better, but you've just lost your life savings at the roulette wheel. Is that seriously the best that we can do for people living with these conditions? There has got to be something better out there. What about commonalities in cellular energetics? I'm going to come back to that word over and over throughout this talk, energetics or energy. All of the conditions we're going to look at, whether it's Alzheimer's, Parkinson's, multiple sclerosis, ALS, all of them have in common problems with generating cellular energy. So of course, when these cells they don't have enough energy, they're going to malfunction. It's as if they're starving and they cannot perform their functions optimally. So a ketogenic type of intervention addresses numerous factors with just the one intervention. So you will see soon that the ketogenic therapies can address the root cause of some of these issues or what might be the root cause. And because it does that, it stands a better chance of addressing multiple different symptoms and multiple different conditions. So, a little bit of history about ketogenic diets. Excuse me, I'm going to take a little drink. I'm sorry, I keep clearing my throat. What a difference 30 years makes, huh? I'm sure many of you watching remember this Time magazine from good old 1984 with the sad face, the frowny face of the bacon and eggs. It was an iconic image. And 3 decades later, here we have a very, very different magazine image. So this is not only 30 years in the making, it's over 50 years in the making. Who remembers Dr. Atkins's first book, Dr. Atkins' Diet Revolution from 1972? 50 years later, we have a textbook, an actual textbook of ketogenic and metabolic therapies. So the low carbohydrate diet, the carbohydrate restricted or ketogenic diet, has gone from this fringe thing that your neighbor down the street did in the 80s and 90s to lose some weight, which that's a good enough thing. That's a great thing. But it's gone from just, Joe Blow down the street doing the Atkins diet to a life-saving, life-changing metabolic therapy at this point. Anyone who calls this a fad diet simply does not know what they're talking about. It's not just 50 years in the making. This is over 100 years in the making. For those of you who don't know, the ketogenic diet was originally developed as a diet to treat epilepsy because they knew since ancient times that fasting could help prevent or reduce the frequency and severity of seizures. They didn't really know why. They just knew that fasting worked since ancient times. Now, the thing is, though, it doesn't really matter how effective fasting is because at some point you have to eat. You can't just fast for your entire life. You have to eat food. Well, they discovered in the 1920s that a ketogenic diet could mimic a lot of the effects of fasting, but you still get to eat food. So that's great. We get to eat all the nutrients and get the energy we need and have some of the physiological effects as if we were fasting. So there's something unique about carbohydrate restriction. There is something very unique when you cut way, way back on carbs, the way it changes your biochemistry and hormones and physiology. At this point, there is substantiated research for the use of ketogenic diets for all of these. And when I say substantiated research, I mean that at this point, the weight of the evidence, the mountainous, the voluminous amounts of scientific evidence are simply undeniable. Again, anyone who says that this is a fad diet or some kind of crazy internet thing simply is woefully, woefully misinformed. So we know that this diet is excellent for epilepsy. You can reverse type 2 diabetes. If you want to learn more about that, we have a course coming up with Adapt Your Life Academy, adaptyourlifeacademy.com. Get on the wait list. We have a course coming up about reversing type 2 diabetes. We know it's great for weight loss, metabolic syndrome, acid reflux, and dyslipidemia. Dyslipidemia is where you have high triglycerides and low HDL, and that pattern B LDL particles, the small ones that are small, dense particles that are believed to be more atherogenic. So on a ketogenic diet, even if your total cholesterol and LDL cholesterol go up, the cardiovascular risk profile improves because of the changes to the triglycerides, the massive drop in triglycerides, the rise in HDL, and the shift in the LDL particle size. So that's substantiated research beyond a doubt. You cannot argue that keto is effective for these things. Keto also happens to be effective for all of these other things. Now, I say that there's emerging evidence and patient anecdotes for these with keto diets because for every one of these, there is published research. There's just not quite as much as for those other conditions, but each of these conditions here has a body of evidence published in the scientific literature supporting the efficacy of ketogenic diets. PCOS, type 1 diabetes, of course, in type 1, you will always need to use some insulin. It's not like type 2 where you can stop your insulin, but people who do keto with type 1 tend to need much, much lower doses And the lower doses of insulin help prevent those wild fluctuations in blood sugar, that really the volatility and the highly unstable glucose levels. All this other stuff, anxiety, schizophrenia, bipolar, there's an emerging field called metabolic psychiatry, because they are studying ketogenic diets and other metabolic interventions for psychiatric issues. All this other stuff on the slide. So I know what you're thinking. I know what you're thinking. You start to become a kook. You start to sound like a crazy person when you tell someone, oh, you have migraines. Have you tried keto? You have lipedema. Did you try keto? You have Ehlers-Danlos. Have you tried keto? Acid reflux, PCOS, non-alcoholic fatty liver, skin tags, acne, joint pain. Have you tried keto? You start to sound like a total crazy person. Like for everything that someone could possibly be experiencing, you want them to do keto. So you know that saying, right? When all you have is a hammer, everything looks like a nail, right? Or everything is a nail. And so that's very true of keto. And I'm going to share with you a quote that I so wish I could take credit for, but it wasn't me. The fact is, keto is a really big hammer, and there are a lot of little nails out there. And that was said by the great researcher, Jeff Volek out of Ohio State University. If you are familiar with low-carb diets, you are well familiar with that name, I'm sure. But whew, feel like I need a cigarette after that sentence. Keto is a really big hammer, and there are a lot of little nails out there. So what is ketosis? What is this keto thing that I keep going on about? Well, the truth is, all you need to know about ketosis is it is a metabolic state where fat is the predominant fuel source. You are metabolizing mostly fat. And when you metabolize mostly fat, you produce these things called ketones as a byproduct. And the ketones themselves are also a fuel source. So when you're on a very, very low carb diet, not only are you fueling yourself primarily on fat, you are also fueling a little bit on the ketones themselves. And the way to induce the state of ketosis, the way to make this happen, is to keep your insulin level very, very low. There's a lot of different ways to do that. The easiest, in my opinion, are carbohydrate restrictions, so a very low carb diet or fasting. But like I said a minute ago, it's all well and good that fasting does this, but you can't fast all day, every single day. Eventually, you have to eat. So you can eat a very, very low carb diet and still experience some of the effects of fasting. To anyone who happens to be brand new to hearing about ketosis, please understand that this is very, very different from ketoacidosis. Just because they both have keto in the name doesn't mean they're the same thing. Ketoacidosis is a very dangerous state that can happen in people with diabetes and occasionally in people without diabetes, but the state of nutritional ketosis, safe, benign, dietary nutritional ketosis, is very different. There's no change to your blood pH, so it's not acidosis. Your blood does not become acidic, and your blood glucose is typically normal, whereas in ketoacidosis, the blood glucose tends to be very, very high. So the most important thing for you to know about ketosis, though, is that when your body is in ketosis, there are numerous other cellular and bioenergetic changes. Remember, I said I was going to say energy, energetic a lot throughout this talk. When you are in a ketogenic state, there's a lot going on differently inside your body than when you are eating a higher carbohydrate diet and fueling primarily on glucose. So let's look at commonalities among diverse neurological and neurodegenerative disorders, because I'm going to be talking about Alzheimer's disease, Parkinson's, multiple sclerosis, and a couple of others. And you probably think that those are completely distinct conditions, and technically they are. Technically, they are unique states. However, when you start looking at what is going on in the cells, in the neurons, when you look at what is malfunctioning, they have so much in common. And if they have a lot in common, then maybe one type of treatment, one type of therapeutic intervention would be effective for multiple of them because maybe they have some root cause in common. So one of the things they have in common, or really the biggest thing they have in common, is that these are energy problems. It comes because of problems with the energy supply to these cells. Neurons are largely intolerant of inadequate energy supply, and thus the high energy demand of the brain predisposes it to a variety of diseases if energy supplies are disrupted. Although neurodegenerative diseases are not classically thought to be caused by disturbed metabolism, bioenergetic defects are emerging as important pathophysiological mechanisms in several disorders. I mentioned that this is sort of a part 2 of the longer video that I did on Alzheimer's disease. For those of you who did not see that, I'm going to build a little bit of a foundation about Alzheimer's and introduce to you how this is an energy problem. And then I'm going to build upon that, and you will see the commonality in Parkinson's, MS, and the other issues. So they now regularly refer to Alzheimer's disease as type 3 diabetes, diabetes of the brain, or brain insulin resistance. Where does this come from? Well, I like to tell people that Alzheimer's disease is a metabolic problem. And when I say it's a metabolic problem, I mean it has to do with the way the brain is getting or using energy. Anytime you hear the word metabolism, think of fuel, think of energy. So Alzheimer's is a metabolic problem, and let's look at exactly what that problem is. The predominant abnormality in incipient late onset Alzheimer's disease was a 45% reduction in cerebral glucose utilization. Don't you think that if your brain is using 45% less glucose, if it's getting 45% less glucose than a healthy person's functioning brain, don't you think you would have some memory problems? Don't you think you might have some personality changes? Your brain is starving to death. That is what's going on in Alzheimer's, to give you the super, super tiny quick nutshell. It is now widely acknowledged that brain hypometabolism accompanies Alzheimer's disease. By the way, all the citations are here on the slides for anyone who's wondering where these quotations come from. Widely acknowledged that brain hypometabolism accompanies Alzheimer's. Hypometabolism means too little metabolism or not enough energy. A prominent and well-characterized feature of Alzheimer's is progressive region-specific declines in the cerebral metabolic rate of glucose. Again, the rate at which the brain is taking up and using glucose is impaired in Alzheimer's disease. And this leads to the signs and symptoms that you see in Alzheimer's. Reductions in that cerebral glucose metabolic rate are associated with increased Alzheimer's disease risk and can be observed years before dementia onset. It can be observed years before the onset of the dementia, this decline in the cerebral metabolic rate of glucose. And I made a big point of this in the Alzheimer's video, but it is worth reiterating here. Alzheimer's disease does not develop overnight. And we're going to see the same thing in Parkinson's, same thing in multiple sclerosis. These things don't just happen. You don't just wake up one day with severe Alzheimer's disease. You don't just wake up one day and you're severely impaired from Parkinson's. These things start much, much earlier. And the thing is, even though, so in Alzheimer's disease specifically, they can detect that the brain already has a reduced glucose uptake in people as young as their 30s and 40s. But people in their 30s and 40s have no signs or symptoms of Alzheimer's. Their brain, they are healthy enough and young enough and still well enough that the brain is compensating. So they don't have any memory loss. They don't have any of those problems yet. It's only when that problem has gone on for so long and become so widespread and severe that the brain can no longer compensate. And that's when you would start seeing the signs and symptoms. That's when somebody would start exhibiting the problems. But the storm was brewing years and years earlier. So this is not something that happens all of a sudden. And in Alzheimer's disease, the memory loss and the personality changes and the behavioral disturbances are the symptoms. That's not the memory loss is not the disease. That's the symptom. The disease, the problem, the malfunction in the brain is this fuel deficit. It's this energy shortage, and it is specific to glucose. The brain, for whatever reason, we don't know the reason really, but the brain has become unable to take up and utilize glucose properly. So the brain is basically starving for fuel. And again, this is something that starts years and years and years earlier than you actually see the symptoms. I know I'm really harping on it, but it's a very important point for you to be aware of, because that makes this so that we need to take this seriously when we're young. Don't wait until you become impaired. Don't wait until you become sick. Don't wait until you become incapacitated. We need to take this seriously now and take whatever potential protective measures we can. And I'm always careful to say potential, because we don't know if we can prevent any of these things. I do believe that we can reduce risk. I think that's a fair statement, that we can reduce risk. Can we prevent it? I don't know. I would never make you that promise. But to the extent that we can reduce risk, that's something you want to do in your 20s, 30s, 40s, 50s. You don't want to wait till you're of advanced age and already in a severe problem. Okay. So I do love the phrase type 3 diabetes or diabetes of the brain, because I think right away that gives us the message that something is going on with blood sugar or sugar, right? But the thing is, you could have many, many problems, metabolic problems, energy problems, without having diabetes. There are, sorry, I shouldn't have shared my slide so soon. There are millions upon millions of people out there whose blood sugar is perfectly normal. The blood glucose, I say blood sugar and blood glucose interchangeably, that is perfectly normal. But it's only normal because they have very, very high insulin, keeping that blood sugar in check. So even when your blood sugar is normal, that very, very high insulin can cause untold health problems. And like PCOS, like skin tags, like enlarged prostate. I've written articles on all of those. Feel free to email me if you're interested. But I just want to point out that the phrase, I love the phrase type 3 diabetes, but it's a little bit misleading, because you can have all kinds of problems without actually having diabetes, because they only diagnose diabetes based on your blood sugar. They never actually look at insulin. So that's just something very important for you to know. So I like to say that insulin is the canary in the coal mine, because the chronically elevated insulin can happen years and years and years before some of these neurodegenerative and neurological or metabolic problems start to occur. Insulin resistance is usually at or near the top of the list of known lifestyle-related factors heightening the risk of declining cognition in the elderly. That comes from Dr. Stephen Cunnane and his group out of Sherbrooke University in Quebec. He is one of my favorite top go-to Alzheimer's research authorities, specifically looking at ketogenic interventions for Alzheimer's. But insulin resistance is usually at or near the top of the known factors. The risk of Alzheimer's doubled in 39% of a sample with hyperinsulinemia and was highest in people without diabetes. What they did is they followed a number of people over a long period of time, and they, saw who developed Alzheimer's disease and who didn't. And the people who were hyperinsulinemic, the people who had high insulin but who were not diabetic, had double the risk for Alzheimer's disease. So again, it's not having diabetes doesn't mean you're safe and free and in the clear. We really, really need to look at insulin, because the people whose blood sugar was normal, so they did not have diabetes, but they were hyperinsulinemic, had double the risk for Alzheimer's. Insulin resistance may be a marker of Alzheimer's disease risk that's associated with the reduced cerebral metabolic rate of glucose, that's the CMR-GLU, cerebral metabolic rate of glucose, and subtle cognitive impairments at the earliest stage of disease, even before the onset of mild cognitive impairment. So the insulin resistance, the chronically high insulin, is the first domino to fall. The actual Alzheimer's disease, the cognitive impairment, all of the other changes that happen are late comers. They are late players to this situation. One of the earliest players is the chronically elevated insulin. So you've heard of metabolic syndrome, right? That is basically driven by chronically high insulin. Some papers used to call it insulin resistant syndrome. I wish they still did. Now they call it metabolic syndrome. People don't even really know what that means, but just know that metabolic syndrome is driven by chronically high insulin levels. And the connections now between insulin resistance, between metabolic syndrome and cognitive problems and cognitive impairment is so strong, that connection is so strong, that they now use the phrase metabolic cognitive syndrome in the scientific literature. And this is just a few examples right here. The metabolic cognitive syndrome, the insulin resistant brain state. Those of you who happen to know of the work of Thomas Seyfried out of Boston College, he is pioneering work on metabolic therapies for cancer, the metabolic approach to cancer. What about a metabolic approach to Alzheimer's? What about a metabolic approach to some of the other conditions that I'm going to walk you through in the rest of this presentation? So just to talk a little bit more about the chronic hyperinsulinemia, if you're a nutrition nerd, if you're a physiology nerd, you will love the book Diabetes Epidemic and You. It's a very skinny book. You could read it in a day. It's a quick read. But this is Dr. Joseph Kraft, and he is the one who really pioneered a few decades ago the use of an oral glucose tolerance test with insulin measurements. So instead of just measuring your blood sugar, they measure insulin at the same time. And he identified the staggering scope of how many people out there had totally normal blood sugar. So again, not diagnosed with diabetes, but their insulin was through the roof and they had numerous health problems because of it. And he wrote, the pathology of diabetes mellitus occurs in those with normal blood sugars. There are far too many who are told, don't worry, your fasting blood sugars are normal. And even having a normal weight, a normal body mass index, and the normal blood sugar, and even normal fasting insulin does not exclude hyperinsulinemia. Meaning, if your fasting insulin level could be normal, but after a meal, especially a very, very high carbohydrate meal, your insulin skyrockets, maybe higher than normal, and stays elevated for a long time. So even if your fasting insulin level is normal, that doesn't automatically mean that you're in the clear here. And he actually called it diabetes in situ, or occult diabetes. Occult means hidden. So the diabetes, meaning the high blood sugar, is hidden. It's masked by the high insulin. And you're going to see that this might be a driving factor in some of these neurodegenerative conditions. You know, we tend to think of insulin as a blood sugar hormone. Everyone knows that insulin lowers blood sugar, but insulin does so much more than that. And it's so radically underappreciated how many other roles insulin plays in your body and in your physiology. Okay, I hinted a little bit earlier that I've been talking the whole time, but to expand upon the commonalities among neurological and neurodegenerative disorders. So I've talked about Alzheimer's now, and we want to expand this to see how some, if not all, of what I've said about Alzheimer's disease applies to these other conditions too. And it's going to be astounding how much they have in common. So one of the biggest things they have in common is neuronal hypometabolism specific to glucose, meaning the neurons, these cells, are starving for fuel. There is a fuel shortage and it is specific to glucose for whatever reason, these neurons are not using glucose properly. So they don't have enough energy, they don't have enough fuel, therefore they are malfunctioning. And the symptoms of that energy deficit are the motor symptoms in Parkinson's and in MS and the cognitive impairment and all those, again, those are the symptoms. The disease is this energy shortage. We have mitochondrial dysfunction, or is it, stick a pin, I'm going to come into that. If you may remember from your high school biology class or your college biology class, that mitochondria are the little energy factories in your cells, the energy generators. So if there's a problem with energy in the cells, then we might conclude or we might suspect that there's a problem with mitochondria. Maybe the mitochondria aren't working right. They're not producing enough energy. That makes sense, but I don't think that's actually what's happening. I think there's actually a very elegant mechanism that they're enacting, but we'll come back to that. Increased oxidative stress. There's reactive oxygen species that can damage the cells and make them not function properly. Now, we hear a lot about oxidative stress and oxidation, antioxidants. We like antioxidant nutrients or your body's own endogenous antioxidants because it helps to neutralize those reactive oxygen species that cause all the damage. But ROS, those reactive oxygen species, are normal. That's a totally normal thing about human physiology. It's just that sometimes it happens too much and it overwhelms, like the amount of oxidative stress overwhelms the body's normal capacity to neutralize and repair. We also see a ton of, well, not a ton, chronic hyperinsulinemia is very, very often identified in people with these neurodegenerative conditions. We see neuronal atrophy. If you watched my Alzheimer's video, I explained that these neurons require energy just to maintain their shape. And you see it on the slide down at the bottom. That's just a very simplified schematic of one type of neuron. It has a very unique shape, and it takes energy just to maintain that shape. And there's a saying in biochemistry and biology that structure determines function, or function follows structure, meaning the way something is shaped determines what it does. So if it's shaped wrong, or if it's, damaged in some way, so the shape isn't the way it's supposed to be, the function is going to be impaired. If it doesn't look right, it's not going to perform right, basically. So we see that in all of these, there's atrophy of these neurons. And because they're atrophying and they don't have the right shape and they don't have enough energy, we have cellular malfunction, glutamate toxicity, and in the final stages, neuronal death, that these cells actually die. Okay. What's the big deal? Like, Amy, you're going on and on about energy and fuel and glucose and da-da-da. Who cares? What's the big deal? Why do we need glucose in the brain and central nervous system? That's CNS, not certified nutrition specialist. This is central nervous system. Why is it such a big deal? Well, as one example, your brain is about 2% of an adult's body weight. It's about 2% of your total body weight. Yet it uses about 25% of all the glucose and oxygen in your body. So like 25% of the fuel, at least from glucose in your body, is going to fuel just 2% of you. So clearly the brain, I said in the Alzheimer's talk, it's an energy hog. Your brain requires a lot of energy. So any disruption in that energy supply could potentially have catastrophic implications for function, right? So apart from that sort of larger overview that your brain just needs a lot of energy, I mentioned just before that these cells have very, very particular shapes, and we need energy. We need to maintain the shape, to maintain those axons and dendrites, those connections between the cells, in order for neurons to communicate with each other. There's an impulse sent out of one neuron and it's received at the next one. In order for that to happen, in order for that nerve impulse transmission to happen, it requires energy. There's no such thing as a free lunch. Maintaining ion gradients, maintaining ion gradients and neuronal resting potential. If you look, cell membranes have electrical charges or electrochemical charges on the inside and outside. Some of it has to do with the electrolytes, electrolytes, because we are electrical beings. So sodium, potassium, magnesium, and in order, your brain has to maintain a certain electrochemical gradient across the cell membrane in order for cells to fire properly when they're supposed to fire, and in order for them to not fire when they're not supposed to fire. So when this membrane potential or this sort of ion gradient is disrupted or not the normal level it's supposed to be, you could, for example, have a seizure. You could have a migraine. Something else could happen. Who knows what, but I mean, those are the two biggest ones that come to mind in when that electrochemical gradient is disturbed. So in order to maintain that gradient, it requires energy. Your brain neurons, you need energy for all sorts of things that you never even really think about. The synthesis of neurotransmitters. We hear about dopamine, serotonin, norepinephrine, all these chemical signaling molecules that do all sorts of things in the body. That requires energy to make them. They don't just appear out of nowhere from a vacuum. They need energy. And then glucose in the brain is a building block for certain compounds that have to be synthesized in the brain because they don't cross the blood-brain barrier. So if your brain needs certain, items or certain molecules or whatever that don't get into the brain, then the brain has to make those things for itself, and it uses glucose as a building block for some of those. So that's, a handful of why it's such a problem if the brain is not getting the glucose that it needs. So, started with Alzheimer's disease, let's shift gears and look a little bit at Parkinson's. The dopaminergic cell loss occurs early in Parkinson's disease, with more than 50% of putamen dopaminergic terminals having been lost before clinical diagnosis of disease. Remember I said about Alzheimer's disease, by the time you are actually diagnosed, by the time you are manifesting the signs and symptoms, the metabolic problem, the reduced glucose, the brain glucose starvation, if you will, has been going on for years, sometimes decades. So the diagnosis is actually the late step. And it appears that something similar could be said for Parkinson's disease, right? By the time you are even diagnosed, you might have already lost half of your dopaminergic neurons, half of the neurons that generate dopamine. Now, what else do we see in Parkinson's disease that we see in Alzheimer's disease? A high prevalence of insulin resistance and high prevalence of undiagnosed insulin resistance, because a lot of doctors simply don't look for it. They test your blood glucose, and if it's normal, they pat you on the back and they tell you you're good to go. So this was a study where 154 subjects, so, not a large study, not huge, but you have to start somewhere. Anytime you see N in a scientific study, that's just the number of subjects. So N equals 54. They found that 58% of them had undiagnosed insulin resistance, but their fasting glucose was normal. So this is exactly what that Dr. Joseph Kraft was talking about. People with normal glucose, but they had insulin resistance. Now, chronically high insulin can make it, can cause weight gain. And they kind of go hand in hand. Chronically high insulin can cause weight gain. And if you are very overweight, it can sort of contribute to you having higher insulin. So it's sort of a chicken or egg thing, but it is not surprising at all that 61% of these subjects who were overweight had undiagnosed insulin resistance. And it's even less surprising that of the people that had obesity, 83% of them had undiagnosed insulin resistance. But the real shocker, or well, not to me, but maybe to you if you're sort of new to this concept, 41% of the subjects who were at a normal weight had undiagnosed insulin resistance, right? And all of these people have Parkinson's disease. And I really want to emphasize here that this was only based on fasting insulin. All of these, not all these people, but this percent of the subjects had undiagnosed insulin resistance based on fasting insulin. But remember, I said there's lots of people whose fasting insulin level is normal. But if you were to eat a meal, particularly a high carbohydrate meal, the insulin's going to go way up and it's going to stay up. So how many more of these Parkinson's disease patients would have been identified as having insulin resistance if they had tested this after a meal or after that glucose tolerance test with the insulin? This slide it's a little bit telling. That's why I'm kind of smiling a little bit. I mean, there's nothing really to smile about when it comes to this stuff, but this is just such an interesting point here. If you know anything about Parkinson's disease, you may have heard of something called the peanut butter test, or you might know that loss or changes in your sense of smell are a potential early warning sign of Parkinson's disease. Now, a lot of other things can contribute to loss of sense of smell. So I don't want anyone becoming terrified that if your sense of smell is altered, that you might be on the road to Parkinson's. It's just one thing. I mean, especially if you have COVID or something, like a lot of different things can affect your sense of smell. But it is well known that loss or changes in sense of smell could potentially be an early warning sign of Parkinson's. And they call it the peanut butter test because I don't know why they chose peanut butter, except that it's delicious and it smells delicious. If you were to hold a jar of peanut butter up to your nose and it doesn't smell like anything to you, that's kind of a problem. So why though? Why would this be? Why would your sense of smell have anything to do with Parkinson's disease? So insulin transport varies among brain regions. The olfactory bulb, your olfactory bulb, which is responsible for your sense of smell and taste. The olfactory bulb tends to have the fastest rate of transport, being about 2 to 6 times faster than the rate of uptake in the remaining brain. The olfactory bulb also has the highest concentration of insulin protein, the highest concentration of insulin receptors, and the highest rate of insulin degradation. Right? I said insulin does so much more than lower your blood sugar. Insulin can and does get into the brain. The brain does need insulin. Obviously, the nose needs insulin, the olfactory bulb. And so if you have problems with insulin signaling, well, then it stands to reason your sense of smell might be altered, right? I mean, it's just kind of like gee whiz information because they talk about that change to the sense of smell. Well, why would this be? This is one potential explanation that there's, insulin is so needed for the function of these organs that if there's problems with insulin signaling, then maybe the function of those organs will be affected. Okay, there's a lot of words here, but I think this is critically important, so I'm going to just read it here for you. There is growing evidence that a process analogous to peripheral insulin resistance occurs in the brains of Parkinson's disease patients, even in those without diabetes. This raises the possibility that defective insulin signaling pathways may contribute to the development of the pathological features of Parkinson's disease, and thereby suggests that the insulin signaling pathway may potentially be a novel target for disease modification. Given these growing links between Parkinson's disease and type 2 diabetes, it is perhaps not unsurprising that drugs used in the treatment of type 2 diabetes are among the most promising treatments currently being prioritized for repositioning as possible novel treatments for Parkinson's disease. It's a lot of words, so I'm going to hammer home the most important point. They are looking at using diabetes drugs for Parkinson's disease. Diabetes drugs for Parkinson's disease. What on earth do these two conditions have in common? Apparently a lot more than we ever thought. Maybe a lot more than you ever thought until right now. So, research dollars are really hard to come by. It's not easy to get funding for a study. So if they are putting money and time and effort toward looking at diabetes drugs for Parkinson's, then they must already suspect, strongly suspect, that there is a connection there. Why else would they be looking at this? They have to suspect that there's some similar underlying mechanisms making them believe that a drug that's effective for diabetes would be effective for Parkinson's. I'll let you ponder the rest of the implications for yourselves. All right, let's take a look at multiple sclerosis. Multiple sclerosis is typically considered to be an autoimmune problem that your immune system is attacking the myelin that surrounds your neurons. So you see on this slide here, two, again, very basic representations of neurons. The one on the left is a healthy, intact neuron. The pink or peach sort of colored stuff is the myelin. Myelin is made out of cholesterol and fats and some other stuff, but mostly cholesterol, that surrounds or sort of encases the axon, and it helps to facilitate neuronal communication. And they call it the myelin sheath usually because it's think of a sword going into a sheath, and so that's kind of like the myelin is protecting the axon. And so the one on the right is degraded. The myelin there is kind of being eaten away. It's degenerating. So it is believed that this is a major problem in multiple sclerosis, that your immune system is launching an attack on the myelin. And the result is the motor symptoms and the other things that you experience in MS. But we're going to look at a slightly different perspective on MS in a minute. But just like Parkinson's, just like Alzheimer's, what do we see in multiple sclerosis? Reduced brain glucose uptake. Patients with MS had lower glucose uptake, or I'm sorry, my picture's on the way, lower FDG uptake in 40% of the brain compared to healthy controls. FDG is fluorodeoxyglucose. It's just a radio-labeled glucose that they can inject you with or infuse you with, and they can see where it goes, and it acts like glucose. And they can tell that MS patients have much, much lower brain glucose uptake compared to people who do not have MS. Decreased regional brain glucose correlates with the level of fatigue, meaning the less glucose coming in, the more fatigued you would be. Walking impairments in patients with MS may be due to network-wide alterations in glucose metabolism. Glucose metabolism. Who is telling you about this? You are not hearing about this anywhere. I don't know why, but this is a commonality in all of these so far. There is a problem with the brain taking up and or using glucose. So these cells do not have enough energy, and as a result, they malfunction. And the signs and symptoms somebody experiences is a result of that malfunction due to the glucose deficit. Not only do we see reduced brain glucose uptake in multiple sclerosis, we see hyperinsulinemia. This was a study they did in newly diagnosed patients, and compared to people of the same age who were healthy, who did not have MS, what they found, and they gave them the OGTT, the oral glucose tolerance test. They had comparable fasting and post-load glucose. So their blood glucose, blood sugar, was about the same between the MS patients versus the non-MS patients. But the newly diagnosed MS patients had much higher insulin levels in response to the glucose. They had much lower insulin sensitivity, meaning they were more insulin resistant. Insulin resistance in MS appears to be tied to the disease severity, meaning the more insulin resistant you are, the more severe your insulin problem, the more severe your MS. So this was, again, kind of a small study, just 64 people. They did the fasting, and now shortcoming again, fasting insulin. Let's see, 14 subjects out of 64 had insulin levels, fasting insulin levels greater than 10. And there's a lot of debate about what a healthy fasting insulin level is. Some labs will tell you that up to 20 or 25 is normal. And most of us in the ketogenic low carb community like to see it below 10. So 15, 20, teens and 20s is not great. Now, you never want to worry about one test, like don't become alarmed if it's just one time and you don't really know the trend. But anyway, I'm getting off message here. This is a long video. We like to see fasting insulin below 10. Some people will say that below 5 is even better. I don't think that we have evidence to really support that. I don't know that we can prove that, but we don't really like it above 10. And out of the 64, 14 subjects were greater than 10, and 33 of them, so more than half of these subjects had insulin resistance based on the Quanto score. And the thing to know is that the Quanto score is based on fasting insulin. So how many more of these people with MS would have been shown to have insulin resistance if this was based not just off the fasting insulin, but after a meal or after a glucose tolerance test? Postprandial just means after, that's the fancy science nutrition word for after a meal. So based solely on the fasting insulin, more than half of these people with MS had insulin resistance. How many more of them would have been shown to have insulin resistance if it was based on more than just the fasting level? That's really the point here. So I said we would kind of look at a different perspective on MS other than the autoimmune attack on the myelin. So let's get into that just a little bit. Mice with experimental autoimmune encephalomyelitis. Now, that's EAE. That is, I'm not going to say the whole thing again. EAE is the animal model of multiple sclerosis. When they induce MS in animals so that they can study them, it's called EAE. In these mice with basically experimental MS, 15 to 30% of spinal cord axons can be lost before permanent motor impairment occurs. Did we not see this in Alzheimer's disease? Did we not see this in Parkinson's disease? That by the time you're even diagnosed, by the time things get really severe, you have already lost a substantial degree of function. So we want to do everything we can to, again, reduce the risk. Or potentially prevent. I cannot, no one can guarantee that we can prevent these things. We really don't know. But the point again is, by the time you're actually diagnosed, you're already in a severe state. I don't think there's any such thing as mild cognitive impairment. There's early onset, but even with something like MS or something like Parkinson's, I don't believe the word mild should, or early stage. There should be no mild or early about it. You're either in trouble or you're not. So the level of disability in the mice correlates more strongly with axon destruction and degree of neuronal loss than with demyelination. So in other words, let me see if axons likely degenerate following demyelination only when they have inadequate energy. So again, if in MS, you can have substantial demyelination. You will have that loss of myelin, but it appears that even if you've got that substantial loss of myelin, as long as those neurons still have enough energy, they can still function well enough to keep you well and quote unquote normal, your normal bodily functions. They really only start to, what does this say? They likely degenerate only when they have inadequate energy. So I'm not saying that the demyelination doesn't happen or it's not a problem, but that doesn't appear to be the biggest problem if you can have some amount of demyelination and still have normal neurological function. So in axons that are degenerating, you have dysfunctional mitochondria. Like mitochondria are the things that are making energy. Then if your mitochondria are malfunctioning, then you don't have energy, and then the axons will degenerate. The axons that are resistant to degeneration resistant axons, they have highly functional mitochondria and they have increased energy generation. So when they have plenty of energy, they have no reason to degenerate. They have more than enough energy to keep themselves alive and healthy. So oligodendrocyte, and there's not going to be a quiz on this, I promise at the end. If this is a little bit over your head, no worries. You're getting the most important things you need to know. This is just kind of digging in the weeds because I personally find it fascinating. Oligodendrocytes are the cells that secrete myelin. They create myelin to give to the neurons. And it has been shown in MS that these oligodendrocytes, these myelin-producing cells, have reduced metabolism, not enough energy. Disturbed metabolism in myelin-producing cells is associated with axonal degeneration. I'm going to skip down to the bottom. Mitochondrial function seems to determine the fate of axons under duress. When your cells are producing enough energy, they can stay alive and have the proper structure and function. When they do not have enough energy, they cannot perform correctly. Moving on really quick, there's so much less research on ALS and Huntington's, but there's a little bit that's worth looking at. So ALS is amyotrophic lateral sclerosis. You might also know it as Lou Gehrig's disease. And then there's Huntington's. And again, here we see that these have in common with Alzheimer's and Parkinson's and MS some amount of disturbed cerebral or neuronal energy metabolism. Dysregulation of energetic metabolism promotes cell death and disease progression in ALS and Huntington's disease. Neurodegenerative cells are the sites of numerous metabolic and energetic abnormalities, with abnormalities in energy production. Energy is the primary determinant of neuronal viability. I'm going to repeat that. It's underlined too for emphasis. Energy is the primary determinant of neuronal viability. These neurons can work pretty darn well as long as they have the energy they need to do so. Compromise of the electron transport chain appears not to be the primary or earliest metabolic change in Huntington's pathogenesis. Rather, compromise of glucose uptake. And I'm going to pause here real quick. The electron transport chain is the system by which your cells generate the vast majority of their energy. A tiny bit of energy is produced elsewhere in the cell, but the electron transport chain inside the mitochondria is where the lion's share, vast majority of energy is generated. So you would think that if energy problems, if problems generating energy are at the heart of these diseases, or maybe not the heart, but certainly a contributing and exacerbating factor, then maybe the electron transport chain is compromised. Maybe there's something wrong with these mitochondria. But that isn't necessarily the problem, because like this paper said, that is not the primary or earliest metabolic change, at least not in Huntington's. The first or primary change is compromise of glucose uptake, compromise of glucose utilization. So when we said, are the mitochondria malfunctioning? When I said, I think they're actually engaging a very elegant protective mechanism. All right, let me stop and elaborate on that here. I said something about this in the Alzheimer's video, where to the extent that chronically high blood sugar or chronically high insulin is sort of overloading the cells, so to speak, and that's an unscientific term, but it's just an easy way to grasp the concept. If these neurons are damaged from years or decades of excess glucose, of what they call glucotoxicity, then your cells are actually doing you a favor by not taking up so much glucose. They may actually be trying to protect themselves and saying, whoa, no thanks. Oh my gosh, we don't want any more glucose. Because when you burn anything in the mitochondria, when you convert anything to energy, glucose, fatty acids, ketones, lactate, all the stuff, you generate those ROS I mentioned, the reactive oxygen species. That's a normal thing. It's unavoidable. It's just the way the human body works. But you can produce too much when your cells are overloaded. Kind of like, I sometimes use the analogy of Lucy and Ethel in the chocolate factory in that very famous episode of I Love Lucy, where, the chocolates are coming down, no problem, nice and easy. And then the system speeds up, the conveyor belt's coming, it's coming faster. There's a lot more chocolate. And now they're overloaded. The boxes are full. It's so fast, they can't keep up properly. Now they're stuffing chocolate in their hat. They're stuffing it in their bra. They're stuffing it everywhere. Again, it's an unscientific analogy, but it's a helpful way for you to think about it. If your cells are overloaded with glucose, then the neurons might be saying, hold on, we don't want any more glucose. Like, we've had enough. We're so damaged. We have too much oxidative stress, too much ROS. Our body cannot keep up with the normal, healthy neutralizing of the free radicals, the ROS. So that's the way of saying, I don't think the mitochondria themselves are damaged. What the cell is doing is simply not taking up glucose. All right. Going along with the critical theme of disrupted energy supply. And why would we use a ketogenic diet? Get to that in a second. While the mechanisms through which the ketogenic diet works remain unclear, there is now compelling evidence that its efficacy is likely related to the normalization of aberrant energy metabolism. The concept that many neurological conditions are linked pathophysiologically to energy dysregulation could well provide a common research and experimental therapeutics platform from which the course of several neurological diseases could be favorably influenced by dietary means. This is a very long way of saying something that I was hinting at earlier, much earlier, where if these conditions have so much in common, then maybe they have some underlying causes or contributing factors in common. And if so, if there is an intervention, some type of therapeutic strategy that would target whatever that underlying thing is, then that one therapeutic intervention, it stands to reason, might be effective for multiple of these conditions, right? And I've been saying all along that the energy problem in these conditions, at least so far as the scientific literature indicates, this energy problem is specific to glucose. So why on earth would we do a ketogenic diet or other ketogenic therapy? Because the problem is specific to glucose. There are, thank goodness, like I said in the Alzheimer's talk, your brain, your nervous system is like a hybrid car. It doesn't just use glucose. It can use other fuels. One of the other fuels we know that the brain especially loves is ketones. And it's been shown over and over, at least in Alzheimer's disease, and it's starting to be shown now in Parkinson's and MS, that even though the glucose uptake is compromised, the glucose uptake and utilization, the ketone uptake and utilization is not compromised. So here we have this wonderful alternative fuel that could potentially be used to power these otherwise struggling or starving neurons. That is basically the rationale for why you would want to have some circulating ketones in somebody with a neurological or especially neurodegenerative condition. So again, the efficacy of the ketogenic diet is likely related to the normalization of aberrant energy metabolism. The concept that many neurological conditions are linked to energy dysregulation. I have a pet theory that I'm going to share with you that, to be 100% clear right now, this is just me speculating. This is me thinking out loud. I think that Alzheimer's disease, Parkinson's disease, MS, all these other things are the same disease, showing itself differently in different people. If they all have the same underlying cause, or at least one major underlying cause in common. At the very, very beginning of this talk, I said something about how there's other causes, other factors. So that, setting that aside, just zeroing in on this aspect, the metabolic aspect, just lost my, oh, right, that when you have metabolic syndrome or insulin resistance, chronically high insulin, not everybody gets all the signs and symptoms, gets all the issues. One of the issues is hypertension. One of the issues is abdominal obesity. One of the criteria for metabolic syndrome is elevated fasting glucose. But not everybody with this insulin resistance has high blood pressure. Not everybody has the high blood sugar. Not everybody is overweight, right? Not like there are different manifestations of insulin resistance in different people. Some women will get PCOS, some don't. Some people get skin problems, some don't. So it's the same underlying problem manifesting differently. And why? I don't know. Maybe different genetic factors, environmental susceptibility. But the point is that we already know that this is true of other conditions where the same underlying factor or factors show themselves differently in different people. And I'm just speculating, my little pet theory, that all of these conditions are maybe not the same, but related. I will call them cousins. They're physiological or metabolic cousins, driven in part, at least, by the same underlying causes, manifesting differently. One person gets Parkinson's, one person shows it as MS, that other person shows it as Alzheimer's. Because when I wrote my first book on Alzheimer's disease, but when I started digging deeper into these other neurodegenerative conditions, I was honestly stunned and fascinated by how similar they look at the cellular level. The metabolic signatures, if you will, of these conditions are so similar. They have just so much in common that it's hard to believe they don't have similar origins. And if they have similar origins, then it stands to reason that the same type of treatment or therapy could potentially be effective for all of them. It's kind of what this whole talk is about, but it's really stunning. It is absolutely stunning how similar these are at the molecular level. Now you've seen what a true nerd I am. Okay. So now that paper, that previous slide said something like, while it is unknown what mechanisms of action the ketogenic diet might be imparting, I have to disagree with that. No shade to those scientists, but we know a lot of the mechanisms of the ketogenic diet. And I'm not going to sing for you because nobody wants me to do that, but cue the Jeopardy music because this is going to go on a while. We're looking at mechanisms of action of the ketogenic diet. Oh, still going. Taking a while here. Still going. Okay. These are only the 16 we know about so far, right? Research into the ketogenic diet has exploded the last several years. How many more things have we even yet to discover? But I will tell you that if there was nothing else on this slide except number one, if this slide only had one thing on it and it was number one, that alone would be reason enough to try a ketogenic diet for any of these neurodegenerative conditions. Why? I hope I've made it clear enough that the problem is a glucose fueling problem, and we can use ketones as an alternative fuel to glucose. Done. End of story. Like that alone right there is a more logical thing in my brain anyway than so many of the drugs out there that are largely ineffectual. That point number one anyway. Point number two, increased ATP. ATP is energy. And molecule for molecule, you get more energy when you metabolize fats and ketones, or when you burn, quote unquote, fats and ketones compared to glucose. So if this is an energy shortage, why wouldn't we want to rely primarily or burn primarily the fuels that give us more energy? And look at number three, to the extent that chronically high blood sugar or insulin is causing or making these conditions worse, then why not tackle that at the root cause? The ketogenic diet most definitely keeps your blood sugar and insulin lower. That's why it's so effective for diabetes. And number 4, I've said the reactive oxygen species are not a problem. It's a normal physiological thing that happens, but it can happen too much. It can overwhelm your body's capacity to neutralize those free radicals. When you are on a very low carb or ketogenic diet, the burning of the fats and ketones actually produces fewer reactive oxygen species, less oxidative stress. And I'm not going to go through all 16 here, so don't worry, but I want to point out a few more. Number 5, enhanced mitochondrial biogenesis. Mitochondrial biogenesis just means making new mitochondria or making more mitochondria. And if these are energy problems, wouldn't it be nice if we could make more energy factories? That'd be pretty sweet, right? And that's what a ketogenic diet does. At least I think it's been shown in animals. I don't know if it's been proven in humans yet or not. So mechanistically, it can potentially enhance mitochondrial biogenesis. Let's see, we don't know the ketones themselves, beta hydroxybutyrate or acetoacetate, these ketone molecules themselves, apart from being an alternative fuel source, they might have other signaling properties that we don't know about that are beneficial in these conditions. If you look at number 11, altered neuronal membrane potential or proper membrane polarization. Remember, I was talking about the cell membrane and the electrochemical, the ion gradient, and how that's really important for proper neuronal function. Ketogenic diets seem to help normalize that or keep the proper balance. That's one reason why keto is often so effective for epilepsy and also for migraines. So yeah, that's all right. I won't bore you with the rest, but that's quite a list. And like I said, if there was literally nothing else on this list but number 1, that would be rationale enough for simply cutting the carbs out of your diet. Now, this is a paper by one of my favorite ketone researchers, John Rowe, and based on everything you saw on that previous slide, all 16 mechanisms, Dr. Rowe wrote, as a generalization, it is becoming and his co-author, as a generalization, it is becoming widely accepted that the mechanistic underpinnings of the ketogenic diet are likely multiple, parallel, and possibly synergistic. So the question remains, can the ketogenic diet be packaged into a pill? At this stage, given our state of knowledge, the likely answer is no. Now, I want to elaborate on this for a minute. When they say, can the ketogenic diet be packaged into a pill? And the answer is likely no. Yeah, because show me a pill, show me a capsule, show me a monotherapy, meaning one drug, one injection, one surgery, a monotherapy, one thing that can do all 16 things on that slide. There is not a pill on earth that can mimic that. There's not a monotherapy, there's not one intervention that can do all of that, but the ketogenic diet does all of that. Now, I am going to talk to you in a bit about other ketogenic therapies. Remember, this talk was called ketogenic therapies, not ketogenic diets, because not everyone wants to do keto, right? Not good luck getting someone who's severely impaired to do a ketogenic diet, especially if it's Alzheimer's impairment, and they're cognitively not there, they're belligerent, their behavior is disturbed. Good luck getting them to do a keto diet. Does that mean that we should just abandon them and good luck, sorry, there's no help for you? No, there are ways to provide some of what you saw on that slide with the 16 mechanisms. The ketogenic diet is the only thing that can do all of them. There are other ketogenic interventions that can do some of them. And some is better than none, right? Especially in light of how ineffective the drugs are for most of these conditions. Okay. Now, this is where the rubber really hits the road, right? Okay, Amy, I'm with you. This is fascinating. I've never heard of this glucose, insulin, metabolic energy aspect of these conditions. Like, I'm riveted, but Does it actually work? Is all this just mechanistic, blah-de-blah nonsense, like pie on the sky thinking? Is this just all wishful thinking hope? No. As one of my mentors says, we don't smoke hopium here. So does it actually work? Like, Amy, I bet it works great in mice. I bet it works great in rats and fruit flies. What about human beings, actual human being people living with these conditions? Let's take a look. I mentioned Dr. Stephen Cunnane and his group. This is one of my favorite papers. I mean, pretty much all of his papers are my favorite, but what you are looking at here is brain glucose and ketone uptake. And if you look at the left from top to bottom where it says CTL, that means control. That is healthy controls, healthy people, healthy brain function. They do not have Alzheimer's disease. MCI in the middle row is mild cognitive impairment, and the bottom row is AD, Alzheimer's disease. And on the left panel, you are looking at the glucose. So the left is the brain glucose uptake. On the right, you are looking at acetoacetate. That is a type of ketone. So the right panel is brain ketone uptake. And I know everybody thinks of beta hydroxybutyrate when you think of the brain ketone. Beta hydroxybutyrate is what you measure in blood if you ever use a blood ketone meter. Acetoacetate is what you measure in the urine. But they're both ketones, and the brain does take up and use acetoacetate. It doesn't just use the beta hydroxybutyrate. That's just the GWAS information. What I would like to point out to you here is that the more reddish orange you see, the more of that fuel is being taken up. So if we look at the top left, that is a healthy brain, the healthy controls taking up glucose. They don't have any impairment. So of course you see plenty of orange there. Their brain is taking up glucose normally the way it's supposed to. The mild cognitive impairment, they're still taking it up. That's why it's just MCI. You know, there's still a little bit, but maybe not as much. When you look at the bottom left with the Alzheimer's disease, there's basically no red orange, maybe a tiny bit. Glucose is knocking, nobody's home. Glucose is not really getting into that Alzheimer's brain all that well. Now let's look at the bottom right. That is the Alzheimer's brain taking up acetoacetate. Look at all that gorgeous, beautiful red orange in that Alzheimer's brain with the ketones. That brain is sucking up ketones like a champ. That Alzheimer's brain is taking up the ketones. It is not taking up the glucose. The authors wrote, not only is the brain energy deficit in MCI specific to glucose, but at least partially correcting this deficit with ketones results in cognitive improvements. Do people have cognitive improvement when they get more ketones? Yes, they do. So here is a look at a study. Now, this is just a case study, one person. It was a 68-year-old male who had mild Alzheimer's disease, and he was a carrier of the ApoE4 gene, which is the strongest genetic risk factor for Alzheimer's disease. It doesn't cause Alzheimer's, but it increases risk. Now, this person he did have type 2 diabetes. He was using insulin for 15 years. His MoCA score, that's the Montreal Cognitive Assessment, that's one of the diagnostic assessments that they use for Alzheimer's disease. He had a 23 out of 30. So he's got, mild Alzheimer's. And they put him on a ketogenic diet for 10 weeks. They added some moderate intensity exercise he was doing 3 times a week, and he was doing 8 hours of TRE, which is time restricted eating. You know that more informally as intermittent fasting. So he had an 8-hour eating window, 10 weeks of a ketogenic diet with exercising a few times a week. Let's see what happened. Well, his MoCA score goes from a 23 out of 30 to a 29 out of 30. So he goes from mild Alzheimer's to normal. His A1C goes from 7.8 to 5.5. So within 10 weeks, his A1C reaches the non-diabetic threshold. His HOMA-IR, which is a measure of insulin resistance, decreases 86%. That's plummeting. Triglyceride to HDL ratio, which is huge in the metabolic syndrome and cardiovascular risk, 55% decrease. His fasting glucose decreases a ton. His fasting insulin decreased radically. A fasting insulin of 97 is very, very high, and it comes back down to normal. He lost a little bit of weight, but whoop-de-doo, and lost a little bit of body fat. The real kicker here is the improvement in his MoCA score. He went on a keto diet and exercised, and his cognitive function improved radically. We have another one here. This is a much younger guy, 38-year-old male, also carrier of the ApoE4 gene. He had metabolic syndrome and he had early memory problems, I think self-diagnosed, if I recall correctly. He does have a family history of Alzheimer's. He was already exercising, so he was not new to exercise, but they gave him a ketogenic diet for 10 weeks. They added some high-intensity exercise to the running and had him lift weights a few times a week. Same thing here. He had a MoCA score of 22 out of 30, and he goes to 30. So he goes, again, from mild cognitive impairment to a normal score. They verified that he was in ketosis using that blood meter, and he had major improvements in the metabolic syndrome. Now, let's look a little more closely at what happened to this guy. If you look at the right there, his HOMA-IR, that measurement of insulin resistance, 58% reduction. His triglycerides came down 71%, 77% reduction in the triglyceride to HDL ratio. BMI, he lost a bunch of weight, all these improvements. But now look at the most important thing here, the bottom left. His MoCA score goes from a 22 to a 25 to a 30, a perfect 30 out of 30. So here is what I really, really want to hammer home for you. When you fix the metabolic syndrome, you fix the metabolic cognitive syndrome. These are not unrelated. The fact that he improved so much in the metabolic syndrome and his metabolic health and his bioenergetics, and the fact that his MoCA score went from impaired to a perfect 30 out of 30, a perfect, normal, healthy score, that is not a coincidence. That is not a coincidence. You fix metabolic syndrome, you fix the metabolic cognitive syndrome. This is the new frontier for Alzheimer's, period, as far as I'm concerned. The drugs are useless. They are useless. They do nothing to address the root causes or what it looks like the root causes are most likely to be. The ketogenic diet addresses the root causes, as does exercise and some other lifestyle interventions. This is the most promising, most encouraging area of research. I cannot stress that enough. Okay, back to the slides. Let's look at Parkinson's disease. Wait, did I miss? Okay. Yeah, that was Alzheimer's. Let's look at Parkinson's disease. Here they compared a low-fat diet to a ketogenic diet for Parkinson's disease. It was 8 weeks. They put these people, Parkinson's patients, on a ketogenic diet or a low-fat diet for 8 weeks. Shortcoming of the study, they are mostly male, mostly Caucasian. You got to start somewhere, of course, but of course, men are affected by Parkinson's more than women. Women do get it, but it's skewed in men. So it's not surprising that the majority of these subjects would be male anyway. They did confirm ketosis via the blood meter. I like when studies say that because then we know for certain that they were adhering to the diet. If we actually have measurable, ketone levels, then we can confirm that they were following the diet rather than, saying they followed it but didn't really do it. Now, both groups, the low-fat and the ketogenic group, improved in all aspects of it's the Unified Parkinson's Disease Rating Scale, the UPDRS. However, the ketogenic patients, the people on the ketogenic part, improved substantially more in the non-motor symptoms. And if you or someone you know is afflicted with Parkinson's, then you are probably aware that for some people, the non-motor symptoms can be far worse than the tremors or the impaired gait. Some of the non-motor symptoms include things like hallucinations, urinary incontinence, the same type of personality changes and stuff. So sometimes the non-motor symptoms can be worse, and the people on the ketogenic diet had greater improvements in those non-motor symptoms. Now, the low-fat diet patients did improve. They improved 11%. The ketogenic group had a 41% improvement. So it's not that the low-fat diet didn't work. The ketogenic diet just worked much better. What else did they find? Well, this is nerdy, but why don't I read it? Because when you're making a video this long, you might as well just make it a few seconds longer, right? Defects in respiratory chain complex 1 activity have been demonstrated in the substantia nigra and frontal cortex of people with Parkinson's disease. It has been suggested that ketones produced by a high-fat, low-carbohydrate ketogenic diet may be able to circumvent this defect through a complex 2-dependent mechanism, thereby enhancing mitochondrial oxidative phosphorylation in the brain. That's just a fancy way of saying energy generation. In addition, such a diet may also enhance central and peripheral neuron energy metabolism by stimulating mitochondrial biogenesis. Remember, I just mentioned that a few minutes ago, that if these are energy problems, wouldn't it be nice if we could make more energy factories? And that's what the ketogenic diet does. And I mentioned the electron transport chain. That's what they're talking about when they say defects in respiratory chain complex 1. The electron transport chain has these different complexes that things go through in order to generate energy. And it seems to be that in Parkinson's, at least in some cases, there may be some defects in the first complex of this chain. Well, when you metabolize fats and ketones, you can bypass that complex 1. So you can still generate energy or generate more energy by burning those fats and ketones. And if there is a problem with complex 1, then a ketogenic diet might be able to sort of get around that. I think that's more speculative maybe, but again, it's just yet another reason why a ketogenic diet might help these things. We've covered Alzheimer's, we've covered Parkinson's, real world, real people, what happens with multiple sclerosis. They did a study of a ketogenic diet in relapsing remitting MS. What happened to these folks? Well, let's see. If you look closely, you can see you have baseline there on the left, or the second column from left, and then you have the change at 3 months. So their insulin came down quite a bit. Their insulin was cut almost in half. But yeah, insulin goes down from 15 to 6.8. A1C drops just a tiny bit. Triglycerides come down substantially. Oh, but wait, yikes. Do you see what I see, everybody? Their total cholesterol went up a little bit, and their LDL cholesterol went up. Yikes. Do we need to worry about that? Oh, sorry. Insulin comes down, A1C comes down just a tiny bit, triglycerides come down a lot, LDL goes up, and total cholesterol goes up. What should we make of this? Okay, so some of those came down, the cholesterol went up, but cholesterol went up. What went down? Depression and fatigue. Now, I'm not saying that depression and fatigue were decreased because cholesterol increased. I'm just saying, should we worry that somebody has higher cholesterol on a ketogenic diet if they have MS when they are actually feeling better? I'll just let you ponder that. I had mentioned in the Alzheimer's talk that there is an exploding body of research. I won't just say growing, an exploding body of research indicating that very high cholesterol might not automatically be any kind of problem on a low-carb diet if all of your other metabolic parameters are excellent. If you are in excellent health and you're physically fit and everything's great, do we need to be worried about high cholesterol? It's an unanswered question, but a lot of the research suggests, no, we don't need to worry, but I'm not giving you medical advice. I'm just pointing out some stuff. Okay. Let's revisit how I said this is ketogenic therapies for neurodegenerative disorders, not ketogenic diet, because ideally you do the ketogenic diet. I mean, that's when I had that slide with all those mechanisms, there is no other way to induce all of those mechanisms except for the diet. But what about those people who are unable or unwilling to do the diet, because it doesn't matter how effective a ketogenic diet is if somebody's not going to do it. So again, are those people just relegated to degenerating? Is there no help? Can we not give them anything? Do we just have to, abandon them? No, there are other ways to give some ketones. And if the number one problem in these disorders is that these cells are starving, and they're starving specifically because they have become unable to use glucose, then let's give some ketones any which way we can. Ideally, we use the diet because the diet stands the greatest chance of addressing the underlying factors, that hyperinsulinemia, the chronically high glucose, if that's an issue, the inflammation, the ROS, like all of these other things that could potentially be causing or exacerbating these conditions. The diet wholesale is going to address all of those. But what do you do if somebody's not going to do the diet? Well, let's look at some of these other ways to increase ketone levels. Beyond the diet, fasting does it, of course. But like I said, when they discovered with epilepsy, you have to eat. You can't just fast forever and ever. So if somebody wants to incorporate some fasting, that's fine. But what do we do when it comes time to eat? Let's eat in a way that mimics fasting. Keto is even very often referred to as a fasting mimicking diet for this very reason. And something else that I want to point out is, specifically in the case of Alzheimer's, but it could be true of Parkinson's or any other condition, frankly, somebody who's elderly and possibly frail, malnourished, or underweight, we would not want them to fast. The last thing we want is to deprive their body of the critical nutrients it needs to restore and repair. So if somebody's underweight or frail, then fasting is not really even a viable option anyway. So even if it's effective, we don't want them doing it. Exercise can raise ketone levels, even in somebody not on a ketogenic diet. If you exercise really, really intensely and you start burning some crazy amounts of fat, you will generate ketones. Now, probably more true of a younger person and a fitter person and a more active person. Just going for a walk probably isn't going to do it. You really have to hit it hard. So somebody who is impaired in some way, particularly if they have MS or Parkinson's or some type of motor impairment, it's going to be really, really difficult for them to exercise to the levels of producing ketones. I'm just pointing out that is still one method, particularly if you combine it with a low carb diet. Coconut oil and MCT oil are another way to increase ketone levels in someone, even when they don't eat a very low carbohydrate or ketogenic diet. The MCT stands for medium chain triglycerides. There are fatty acids of a certain length, a medium chain fatty acid, that your body, your liver specifically, will convert into ketones even when you eat a high carbohydrate diet. It's just the way these particular types of fats are metabolized, that even when you're not on a keto diet, consuming these oils will elevate your ketone level. And so MCT oil may be a little bit more potent because it's all those medium chain fats, whereas coconut oil contains some medium chain fats, and then it has some other types of fats that are not as readily converted into ketones. So if put MCT oil in a shake, cook with coconut oil, bake with coconut oil, get these oils into these people any which way you can. And exogenous ketones, kind of the same thing. When there was that slide, can the ketogenic diet be packaged in a pill? No. But the closest thing we have to it at the moment are the exogenous ketones. Exogenous ketones come primarily in a powder form, and you mix it into water, and it's beta hydroxybutyrate, and you just drink it. And there's another form called the ketone ester, which is also something that you drink, and they're working on a few different formulations. It's not very pleasant tasting. It's not that great, but it's come a long way. Anyway, these will raise ketones more than the MCT oil and the coconut oil, but they're very expensive. They're readily available. You can get them online. But anyway, Yes. This is what I said in the Alzheimer's talk, and I'll repeat it again here. If the brain, if these neurons are starving, then we need to fuel them any way we can. So get ketones into these people any way you can. But providing these exogenous ketones or ketones from MCT or coconut oil is like bailing water out of a leaky boat without stopping to patch the hole. You're sort of managing the symptom, but you're not addressing the underlying problem. Now, if somebody's severely impaired, like if they're in the late stages, sort of end stages, just let them have peace. Maybe give them the ketones, because at that point, we're not really trying to address the root cause. They're so far gone, you just are not even going to put a whole lot of effort into trying to correct things, trying to correct that situation. So I absolutely think that there is a time and a place for the exogenous ketones and the MCT oil. Even for someone in the early stage, it's fine to use, but to the extent that someone is willing and able to implement and adhere to the ketogenic diet, that's really the biggest mover. That's sort of the biggest lever, or it's a small lever that's going to move a big load, right? If you really understand the physics concepts. So not that I do, I know this much physics. So, but you can do it all. Do a ketogenic diet and take MCT oil and use exogenous ketones and exercise. These are not mutually exclusive, but obviously that's easier to do in somebody younger, someone more able-bodied, someone less impaired, and someone who has a lot of support, who has a lot of family support, caregiver support. I think actually, shame on me, I neglected to mention this in the Alzheimer's talk, that the caregiving role is sometimes the most difficult of all. Not that the person afflicted isn't suffering and having problems, but the loved ones that have to watch it happen and who feel powerless. So to the extent that you can help your loved one not only maybe improve their own situation, that removes some of the burden from the caregiver. Because if the person they're caring for is starting to do a little better because of a ketogenic diet or because of exogenous ketones, then that person can breathe a little bit easier, or just have just a little respite, a little bit of hope and of promise. So there's definitely reasons to use any and all of these. You can mix and match. It doesn't have to be one or the other. Why wouldn't you hit it with everything you possibly could? Why wouldn't you do everything that was within your power and within that person's capacity and desire to do? Coming into the end, I promise we're almost done. I just said, if someone is in the end stage, really, really severely impaired, why would you waste a whole lot of, not waste, that's the wrong word. It may not be the best use of your time and effort to try to reverse it. It may be best for that person, best for the family, to simply let that person have peace in the remaining time that they have. And so this also is from that researcher, John Rowe, and his co-author. One potentially important consideration applicable to all neurodegenerative diseases is determining whether timing of intervention is crucial for a protective effect of a ketogenic diet treatment. Neurological disorders in late stages of progression may have such extreme neuronal dysfunction and death to allow refueling with metabolic substrates to help recover integrity and function. This basically means there may be a point at which it is simply too late. The person is too far gone. The disease is too far advanced for the ketogenic diet to actually do much. I still think it's always worth trying. It's always worth trying. It's never too late. I would never say never give up. But in cases like this, you are more likely to get that temporary improvement, or to improve this person's life in the time that they have left with the exogenous ketones and the MCT oil, as opposed to trying to put them on a ketogenic diet. So I do think there is a time after which it is too late to have a beneficial impact, but I would not let that stop you from attempting with some of these other interventions that could potentially at least improve that person's quality of life and their loved ones in whatever time they have. Okay. I hope that after everything you have seen, and if you've made it this far, thank you. You're a trooper for hanging in there. But I hope after everything that you have learned, your answer is no longer, why would somebody try a ketogenic therapy? It's why would you not try a ketogenic therapy, right? Now, the existing tools are not getting the job done. The medications we have are lackluster, and that is putting it really, really mildly. Existing tools are failing. Maybe it is time for that big hammer, like Dr. Volek talked about. Maybe it's time for that big keto hammer. If you would like to learn more about this, again, this is my book, The Alzheimer's Antidote. You can find it on Amazon. And I hope that I've conveyed through this presentation that so much of what I say about Alzheimer's and so much of what I wrote about Alzheimer's in this book may also be applicable to Parkinson's disease, multiple sclerosis, possibly to Huntington's, possibly to ALS, and some other types of impairment. So if your loved one is not dealing with Alzheimer's, I would say don't let that stop you from reading this book as a way to get a good underlying foundation that might also be applicable to your loved one's situation or maybe your situation. And there's a physician and researcher named Mary Newport, Newport, Mary Newport. She's written a couple of books about ketones and ketogenic therapies, and she covers a little bit more Parkinson's and MS and all of that stuff. You can look her up on Amazon. She has a few books. But anyway, thank you again for hanging in there with me. Thank you for coming on this very, very long journey, but I hope it was a very educational journey and an eye-opening journey. My website is stallslayer.com. If you are interested in a consultation, I do provide individual consultations. If you would like to work with me one-on-one for your own situation or to confer for a loved one, stallslayer.com. There's a work with me tab. My other website is toitnutrition.com. I haven't updated it in ages, but that's my blog. I used to be a blogger long before I was making videos. I was a prolific blogger. So if you care to read, if you're a reader like I am and you'd like to go through lots and lots of stuff about keto and low carb and weight loss and metabolism and thyroid and Alzheimer's, toitnutrition.com. Follow me on Twitter. If you're on Twitter, I'm at toitnutrition. I'm also on Facebook, and I would love if you would subscribe to the channel. Please share this video far and wide. I hope that it reaches people who could benefit from this information. And I'll be talking more about this on my channel. And I sincerely hope that this was educational. I don't know why this isn't talked about more widely. There is so much that we don't know about these disorders. Absolutely. I am by no means suggesting that we know everything or we've got all the questions answered. Absolutely not. But we know so much more than we think we do. We have so much more power than we think we do. And we are not helpless. The situations are not hopeless. We are not left to just throw our hands up in despair. There is something we can do. I think this metabolic trajectory, this metabolic origins explanation for some of these conditions is far more promising, and it fits the pathophysiology so much better than some of the going theories, so to speak, than some of the conventionally accepted theories and explanations of these conditions. So again, I hope this was helpful. Please subscribe to the channel. I do keto without the crazy, and I try to help other people do it too. Thank you so much, and I'll see you next time.